My name is Gerard Rockenschaub. I'm the Regional Emergency Director in the WHO European region. And together with my colleague Benjamin Schreiber from UNICEF, we will be the co-moderators hosting you in this afternoon session here. Before starting, I would perhaps like to use the opportunity to introduce our panelists here, and would like to then ask them to join me here on the podium. We have from Türkiye Dr. Alagüney, Deputy Director General for Public Health from the Ministry of Health. Dr. Alagüney, thanks for joining us. We have from Nigeria our colleague Muhammad Lawan Gana, the Health Commissioner of Yobe State in the northwest refugees response. We have from Ukraine the WHO representative for the Ukraine country office, Dr. Jarno Habicht. Jarno, please. And we have from Poland our colleague Dr. Katarzyna Drążek-Laskowska, the director of the Office of International Cooperation in the Ministry of Health in Poland. Thanks for joining us. Colleagues, perhaps a few words, if you allow me to set the scene a little bit. I think it's basically undisputed that primary health care is a key pillar to address the health challenges in emergencies. And if we would have needed reminders of this, I think some of the crises that are affecting us, in particular in our region, but more globally, are actually a stark reminder how important primary care services are. I'm actually just back from a 1 week's mission to Ukraine, and together with Jarno's team, we went to Kharkiv, Zaporizhia, to Mykolaiv, and then we had the opportunity to hand over to health workers there a prefabricated container unit to replace their facility that has been destroyed by an attack on healthcare. And the perspective of hope that this was providing amongst the health workers, but also amongst the patients gathered there, was really touching. I think another reminder was the earthquake in Turkey that affected our region in February, where we had an unprecedented deployment of international emergency medical teams. 42 international teams were deployed to work side by side with Ministry of Health units, with the UMKE team there. The interesting thing was the biggest demand were primary care services, and despite the fact that they had surgical capacities, intensive care unit capacities with them, they were mainly dealing with providing primary care services. And then the last word on the recent escalation between Israel and Gaza, a very sad tragedy that is affecting us, our region, and the people in Gaza and the people in Israel. Just the latest figures from the Gaza context, 66% of the Ministry of Health primary healthcare facilities are no longer functional, and 64% of UNRWA, the biggest humanitarian player, are also no longer functional. 2/3 of the primary care facilities have been knocked out. We need to protect health services in conflicts, and health, including primary health care, can never be a target in conflicts. I think with that, I would like to ask for the video to be played, which will give us a bit of a perspective on non-communicable disease services and the primary health care in Ukraine. If we can have the video, please.
Під час війни родини з маленькими дітьми неохоче покидають свої домівки і приходять на прийом до доктора. Тому домашні візити – це дуже важлива підтримка родин в такий час.
Патронажная медсестра, она приходит регулярно. Вопросы были у нас.
We had questions about proper care for our child, bathing, nutrition. Mic is off. Mic is off.
Colleague Amirhossein Takian, technical advisor for the WHO Eastern Mediterranean Regional Office. And Dr. Takian is talking to us about primary healthcare, multi-sectorial policy and action response to the COVID-19 pandemic and other health emergency situations in the Eastern Mediterranean region. Dr. Takian, the floor is yours. Thanks.
Thank you very much, and very warm good afternoon to everybody, and thanks for the government of Kazakhstan, UNICEF, and the World Health Organization for managing this wonderful session in Historic City. What you mentioned, Gerard, the movie, what we watched, is setting the scene that what I want to say, which is about how we can actually use PHC facilities during the emergencies. This doesn't work, I guess. Okay. Let me go back. So primary health care is the fundamental aspect of emergencies and the fundamental aspect for maintaining health security. What we saw in Ukraine, what we are witnessing that now in the Middle East, is the evidence that why we need that. And that's why when we have the primary healthcare approach, we can at least have some kind of peace of mind that some basic services are there when conflict happens. And I come from the region that we are not running short of conflicts, not just the man-made conflicts, floods, natural disasters, terrorism, and everything affects people. And then primary healthcare has at least two rules. The first thing is reaching out to people when something happens. That's the only available facility in many places. And then keeping up the resiliency of the health system. That's the second thing which is important. Health system approach without PHC is not resilient enough within the emergencies. If you look at the literature, you can see that in the course of last 10 years, after the Fukushima tsunami and then after the COVID-19, you can see the surge in terms of preparedness and emergency in PHC. The number of evidence and published literature is going up. But the thing is, almost 47% of this literature is for high-income countries. So that's the deficit. We still lack having enough evidence how we can prepare our PHC in the low and middle-income countries when emergency situation happens. So for that, we need more action. We have been talking about this since this morning. PHC has three interrelated synergetic aspects. One is essential public health functions and core integrated health services. And specifically, look at COVID-19, for instance. If PHC wasn't there, some people with long-term conditions, like cardiovascular diseases, routine services, diabetes, and other things, you have nothing in some places to do. So routine services is very important. The second thing is multi-sectoral policy action. Again, I bring at the end of my talk some examples from the Eastern Mediterranean region, saying that how engagement with the civil society, with the public, and as co-designers of the health system is at the core of the PHC, and empowering people and communities, because risk communication, the context of vulnerabilities, emergencies matter. It matters a lot because when PHC is there, it is tailored to that particular context, which we come to that in a minute. Emergency. What is emergency? A type of event or imminent threat that produces or has the potential to produce a range of health consequences. So we face health consequences. Among those could be death, could be morbidities, could be disabilities. So these are very important ones. And which requires coordinated action, usually urgent and often non-routine. So we're talking about non-routine care embedded within the routine facilities as PHC. Pandemic, disasters, wars, conflict, emergencies are context-specific. And because PHC, at the heart of its philosophy, is context-specific, that's why PHC can help in emergencies. PHC approach is an essential foundation, and building community and resilience is a part of the PHC. And fundamental role of PHC in preventing, preparing for, responding to, and recovering from emergencies should be noted very, very vividly. So that's why we believe a PHC-oriented system supports resilience, meaning what? Meaning that we can continue providing the services during the emergencies while the health system is still in function and other things are in function. The PHC PHC in emergencies can provide essential routine healthcare service, and as I said, specifically for the long-term conditions and for the vulnerable people, identify and manage emergency cases. For instance, in the case of my home country, Iran, we use our extensive PHC within rural settings for case identification, for somehow preventing the spread of the diseases, for empowering the communities and providing them with information. Preventing diseases outbreak with effective operational function, key role in disease surveillance, and this disease surveillance is very important. If we don't just imagine in rural places, in Africa, Middle East, and in many low-middle-income countries, if we don't have PHC, how on earth can we gather information? So PHC is the most important network for surveillance and gathering information. And that's why PHC promotes not only an effective emergency response, but also a prepared system which can recover from emergency. So that's why emergency situation without PHC is very much more vulnerable. And this is just the capture of what I said. This is the algorithm, shows how primary healthcare facility approach can prevent more disasters during disasters. And that's the key term. The disaster happens that way. When we have PHC, we can prevent more disasters and we can contribute to the resilience of the health system, because that's the only facility existing. In terms of leadership, service delivery, health information system, sometimes, as I said, there is no other facility and no other mechanism than PHC to gather information and data. Medical products and technology, and financing. Sometimes microfinancing within a PHC can happen, which unfortunately we don't have time to go through that. My ultimate message here is we have to strengthen PHC for vulnerabilities and emergency situations. Without primary health care and PHC-oriented health system, there is no health security. Why that's the case? We need to orient our health system to PHC and strengthen the emergency risk measurement and risk management. PHC can contribute that we have the society with us and we can gather information and communicate with the society when there is no other facility whatsoever. The second thing is focusing on communities, individual and health workers. Again, PHC is a vital resource to bring different parts as a co-designers of the health services, which is a part of public participation and social participation. The third one is improving financial infrastructure and strategy health. Which is sometimes compromised in emergencies, and then we need to use the PHC, which is very trustworthy, to enhance trust when the information goes by people in the PHC, like for instance the lay healthcare workers, people trust them. So it's the best mechanism when it we had an earthquake in Afghanistan just 2 weeks back. So international aid comes, national capacity is there, PHC the best platform in order to absorb national and international helps in order to reach out to the population. That's why PHC matters a lot. And just my last point is, during COVID-19, in the EMR countries, in the Eastern Mediterranean region, 22 countries, we had many experiences. We are in the region that some of the most high-income countries and some of the low-income countries are located there. So you can imagine that we have 3 groups of countries, and it's specifically in group 3 and somewhat in group 2, which are low and middle-income countries, we had some issues. For instance, PHC workers were insufficiently informed about their preparedness. So now, with the case studies that we have done, one of the very concrete lessons is we need to prepare our workforce for emergencies, having training, having capacity building and courses. Another point is the national PHC-specific strategy for COVID response. So the next pandemic is very likely. No question that it will happen. In our region, unfortunately, including my home country, even though we have a very extensive PHC, we largely invested in secondary and tertiary care during COVID-19. So it needs to be some mechanisms in order to somehow focus away our attention from this kind of very state-of-the-art hospital facilities towards the future, because this is more cost-effective, this is more efficient, and this is perhaps the only way to do that. And most countries demonstrate a strengthening role of PHC. That's why the next mission in our region region is focusing on PhD in a way that we can be more prepared for the next pandemic. So my main message, without PhD, we cannot manage the pandemic, we cannot manage vulnerable people during the emergencies, and we cannot reach universal health coverage, health security, and health resilience. I'll leave it there. Thank you.
Thank you very much. Thank you very much, Dr. Takian, for setting the scene and giving us the perspective. Challenge in your country in absorbing and addressing the health needs of the huge number of migrants.
Thank you very much for the opportunity to share our experiences. This is an important question, but I will try to emphasize my answer on the technical side and the primary healthcare services provided by the Ministry of Health. In September 2023, we have approximately 3.5 million Syrians in our country, and Syrians under temporary protection who are registered in Turkey can benefit from healthcare services, both primary healthcare and going up to the secondary and tertiary healthcare. They can access those services free of charge, and they are covered by the system. We have accommodation centers which these Syrians under protection reside. They are called temporary accommodation centers, which are run by the Director of Migration Directorate, and the health services in those places are provided by the emergency services, by 112 emergency centers and migrant health centers. These migrant health centers are like reciprocity of our family medicine system. For every 4,000 Syrian, we have one physician and one nurse or midwife giving them the primary healthcare services. It's important because it's established as a service to improve the capacity deficiencies and overcome language barriers, because the physicians are Syrians themselves that give the service to these people. And outside the temporary accommodation centers, we also provide primary healthcare services like our own citizens use. The family medicine units can also give them these services. These migrant health centers, as I said, consist of at least one physician and a midwife and nursery. They're established according to the same standards as our family medicine units. There are now 194 migrant health centers located in 32 different cities, and there are 866 units. This you can multiply with 4,000 and it approximates to 3.5 million. So we have the capacity enough as we give the capacity to our own citizens for these people. These services are funded by the SAHAT project after 2017. It's a contract concluded by the delegation of the European Union in our country and the Ministry of Health in Turkey. We also provided a further and more complex service to those people when there's a high population of Syrians under protection, and if the place is far from a full-fledged hospital, we invented something called reinforced migrant health centers. And these give also services in the field of pediatrics, gynecology and obstetrics, oral and dental health, and psychosocial support to those people. Like a mini hospital, these services provide both primary care and further care. We also have units called foreign nation polyclinics. They are outpatient clinics exactly, and when there is no migrant health center or a reinforced migrant health center, we give services, primary care services, by these outpatient clinics. And there are currently 99 clinics in Turkey, in 77 provinces. We have also tried to emphasize on the vaccination status of the Syrians under protection, and it's going with our national vaccine calendar with the expanded immunization program. In this context, over 11 million doses of vaccination were administered to the Syrians under protection. So I thank you, and this is the brief explanation of the question.
Thank you. Thanks a lot for this example. My name is Schreiber from UNICEF. I'm Associate Director for Global Health Partnerships and glad to co-moderate here. So, Dr. Mohammed, can you tell us from your experience what are some of the major challenges to providing humanitarian aid to the victims of long-lasting crisis? And how do you deal with this sort of long-lasting chronicity of these crises?
Okay, thank you very much. Let me begin by expressing appreciation for being part of this panel. In order to answer, I think there is need to take a little step back to, provide context, a description of the region that we'll be talking about. It's in the northeastern part of Nigeria. It's a region that has a population of about 26 million people, with a landmass of over 20,000 kilometers square. That is 1/3 of the landmass of Nigeria. The major problem that happened, the major cause of the displacement was the Boko Haram insurgency, where, on the surface, the reason for the insurgency basically is being aversive to westernization and Western education. But then, of course, digging deeper, we all know that it's all about, power and resource control. That has led to destruction of primary healthcare systems in addition to, the displacement of the population. We have destruction of primary healthcare facilities, schools, and other places. The displaced population is about 2.3 million people, but about 2.1 million people were resettled. The resettlement basically is in three forms. Some, returned to their, original settlements, about 750,000 to 800,000. Others integrated themselves into the host communities, about 1.5 million people. Some, of course, stayed in makeshift camps. When you look at all this, of course, there are challenges because the region is also a region where you have difficult terrain, hard to reach areas, rocky, sandy, and other things. So all this, will constitute challenges to delivering humanitarian aid. But then, of course, the first challenge basically is the issue of, leadership, governance, coordination at those levels, especially at the local government and community levels. And then, of course, communication, vertical and horizontal communication between the partners, the humanitarian actors and the government, the humanitarian actors and the communities, as well as, between the humanitarian actors because of issues around duplication. The second challenge basically is around funding and resources. The issue is that, like I described, in addition to the delivery of aid, and looking at the population, it's a huge population, and then, building back to the way it is supposed to be, what we call the building back better. So you find that a lot of resources are actually needed. So, and of course, basically, we know that resources are never enough. The third challenge basically is around local capacity to deliver humanitarian aid. It's a new thing to the population. So, of course, the local capacity is not as strong as it needed to be. So, of course, they need to build additional capacity to deliver humanitarian aid. The fourth issue is that while this is going on, other issues around displacement or causes of displacement also came up. For example, natural disasters. Because of the climatic change, you find that we had flooding, we had famine, and this is a population that is already poor, so it further impoverished the population, so the need also has increased very significantly. The other challenge is, I think, the mode of delivery of what to deliver, the kind of aid. That is going back to the adage that says catching a fish and teaching how to catch a fish. So this is a population that, they are settling in host communities or they are going back to their communities. Of course, there is need to really not only give them the aid in forms of food, but then is also to enable them to looking at the way they live and then enable them to be able to, empower themselves. So, of course, looking at, agriculture, giving them the opportunities, modern seeds, and all the inputs, agricultural inputs that they'll be able to, go back to their farms. The second thing is around education. But then very important is around health, especially primary health care, because when people are being settled either in the communities or in the locales, of course, there is need for them to, you need to provide all that. The other challenge is around the shrinking, humanitarian space because of the global crisis. How do we deal with this chronic thing? I think I will really express appreciations to UNICEF and WHO and BMGF for all the support that they've been providing, the work they do in primary health care, the work they do in creating awareness amongst the population, the work that they do, and of course we collectively work in creating coordination, because that is a need to deal with the chronicity of crisis in an environment. And then, of course, providing leadership and engaging and working with the local communities. And very important is also understanding the population dynamics, and then the context of the populations. I'll just take another step outside the question, but then to just talk about the need for, putting in place very strong primary healthcare systems, functional, around that, which of course we are working, especially establishing functional primary care systems in each of the wards, so bringing care as close as possible to people, and then working with our partners, WHO, UNICEF, the Bill and Media, through our primary healthcare memorandum of understandings that were signed with the government to strengthen primary healthcare systems in those communities. So that way you are able to establish systems and of course establish resilience in those communities. Thank you so much.
Thank you very much, Dr. Gana, for this perspective from Nigeria. Let me turn to Dr. Jarno Habicht now. I think we already got a glimpse of WHO's work in the very difficult circumstances in Ukraine from the video. Could you give us a bit of perspective what WHO is doing to provide access in that context and what role the primary care services play there? Jarno, please.
Thank you, Gerard, and thank you for having me. And I will give a few of the examples from Ukraine, and really to complement also to the keynote, which says we should invest to primary care all the time. And this is something that we have been doing and discussing 45 years now, and I think we need to do further. So 5 takeaways when I look back to and in Ukraine. First is really what is important is to invest to the primary care, and Ukraine embarking the reforms in 2016 on health financing, digitalization, but the primary care was really in the center. I will not dwell into all the details. You can go one floor down, there is a poster, have a look. And, but what is important that the primary care really has been in the center of reforms. And coming now to more to closer to the war, what we have also seen as a WHO, we have been monitoring how primary care adapts already at the COVID time. And what is interesting to see, while primary care goes through the crises, for example, in the last 600 plus days of the war in Ukraine, the primary care needed much less of adaptation because it did much more of adaptation already in the COVID time. So kind of COVID prepared the primary care to be ready for the crisis and the emergency management. So I think that is something important to take away. However, so we can first message really primary care in the center of reforms, adaptation through the crises, and that gets you ready. Now, the second is really how primary care can be agile and responsive. And this is something that we have seen in Ukraine, the primary care really to adapting. So I will come back, Gerard, to more what is happening in the front line. But what we have seen really primary care adapting as there has been a huge population movement, and my colleague will talk more what is happening outside of Ukraine. But when we look inside of Ukraine, we have more than 6 million people who have moved across the country. But what the primary care does, and when we did a study a year ago for the first year of response, we see that the 58% of the primary care units are doing actually outreach services of vaccination in the IDP centers, so it works as an outreach when we need to ensure the vaccination coverage. We also see that they have adapted inside, also providing other services, as well responding to the new needs. As the mental health rehabilitation, we have seen that the 60% of primary care units, they have adapted to new needs, and that is extremely important, that the primary care is very agile also in responding. And that means also that 3 out of the 4 primary care doctors and nurses, they have got also new trainings. So that's very, very important. Even at the crisis time, when you need to respond, you need to ensure that your primary care system is trained and the new skills are given to them to be able to respond. So primary care that is agile and responsive is extremely important. Then the third, primary care as an outreach service, and this is something that in the keynote was also highlighted, the importance as well what we have seen in Ukraine and what, Gerard, you were visiting the center near to Kharkiv. But what we learned after in last year in Irpin and Bucha and many of the regions like Chernihiv, we saw that the primary care needs to be built back. And when we really ensured that the national system can be built back. We relied on the emergency medical teams who were international in the beginning, but mostly it was the Ukrainian nurses and doctors who provided the services. And that's important because that's the trust that you have with the patients, with the community, with the people, that we need to also rely on. So as a WHO, we have supported more the Family Medicine Association, the doctors and nurses, to go back, and that allowed to have tens of thousands of visits in the first 6 months of the invasion, and to ensure that the services are available. But we need to also adapt what type of services are needed. And very often we think about the trauma and injuries, but actually it's the non-communicable diseases that we need to address. We saw that every 3rd patient actually needs to be treated for the hypertension. And that's where we needed to put really our development thinking and emergency thinking together, how to ensure that medicines are available, because also in the beginning of the war, we saw that 65% of the pharmacies were closed. So how we ensure that also medicines are available. So when we talk about primary care, we should not forget also the medicines, something that Natasha was also telling us in the first session. So, and now, as the winter is coming, exactly the point is about the emergency mobile, the prefabs and the container units which are there. So, outreach. The fourth point is the new services and mental health, and I will do very quickly. I see that you are sending me a message. But what is important, we need to really train the primary care to give mental health services, and there the tools like MHCAP and others are useful. So what has been useful and important for the population, that through these trainings of the primary care has potential now to reach out 13 million people in Ukraine. The needs are huge. The outreach needs to be there, but we need to equip the healthcare workers to be able to provide those services, and this is to continue. And the final point is really, when I see half of the primary care units attacked, what Gerald, you were also mentioned, we see half of them already restored. And that is important message of hope. Recovery starts actually in the first days of the crisis. So we need to ensure that the primary care centers are restored. We need to ensure that actually system is functioning, because that gives the hope also to the community. So really, primary care in the center of the reforms, primary care that has shown the agility during the time of pandemic and the war, ensure that the outreach services are there, that we restore the services and the trust of the community, that ensure the new services like mental health are covered, and finally that we also invest to the hope, trust and recovery. And the colleagues, if you find that type of card in the conference, there are more information for all of you. So happy to contribute, and I hope I fit to 5 minutes that you gave me. Thank you.
Yes, thanks. No, thanks. We are running a little bit behind, but it's okay. We stay in the region. Dr. Katarzyna, your country welcomed a lot of refugees from the Ukraine also into your territory. So what were the main consequences of this for your system and for the workforce? And what concrete actions should be taken to overcome these difficulties?
Good afternoon, everyone. It is a great pleasure to be here with you, and thank you for those questions. I would like to share some good practice with you from Poland related to welcoming refugees and ensuring access to primary health care in emergency situations. But at the beginning, let me highlight some basic facts to better understand the scale of challenges in Poland. I refer to the aggression of Russia against Ukraine that caused the biggest migration crisis in our region since World War II. Since the beginning of war, over 14 million of Ukrainian refugees came to Poland, and at least 12.7 million left. So we can say that about 1.3 million of people are staying in Poland because of war, of course. The cornerstone of assistance to Ukrainian refugees is the legal provision that every citizen of Ukraine who came to Poland after the 24th of February last year is entitled to medical care on our territory, including PHC. So this is the first moment when I would like to mark our good practice, leave no one behind. The challenge for healthcare system is, of course, huge. We had to absorb millions of potential new patients to our healthcare system. According to the latest data, since the beginning of the war, about 850,000 patients received assistance in primary health care. Some of services are funded by UNICEF, but mainly we are financing these visits from state budget. There are no specific healthcare facilities for Ukrainian refugees, so this is another good practice to mark. Do not create divisions in healthcare facilities for our and their patients. Try to integrate the refugees into existing system from the very beginning and engage all medical facilities in providing help. Another good practice I would like to mark: cooperate with your friends, with your partners. Don't do everything by yourself, especially if you can count on support. Your capacities are always limited. So this is the place when I would like to thank for our friends and partners, governments of other countries, NGOs, and of course WHO and UNICEF. Related to, I would like to refer, of course, to your questions related to medical workforce. This is, of course, the most important part of our response. The healthcare workers had key role, but I would like to underline the human dimension of response to the crisis. Nothing what was achieved already would be possible without huge dedication of ordinary people, including healthcare workers. To match the needs and the opportunities of healthcare workforce, Ministry of Health launched the program of simplified access to labor market for doctors, dentists, nurses, and other medical professionals. It is a shortened path with no obligation to validate a university degree. This is really important. To obtain the right to practice a profession in Poland with for maximum period 5 years. The regulation for nurses, midwives, and other professionals are quite the same, and they are also simplified in a similar way. It is really important that we've got Ukrainian-speaking professionals. So they are supporting us in providing healthcare for Ukrainians, but not only for the Ukrainian refugees, also for the Polish citizens. This is a really, really important part for us at a governmental level. The simplified procedures is dedicated not only for the Ukrainian doctors and nurses and professionals, but also for citizens from other countries outside the EU. For example, United States, United Kingdom, Canada, Japan, and Israel. If they would like to come to Poland to support migrants, we are very open, and we've got some simplified procedures for them. What is more important, we dedicated a special hotline for doctors and dentists who obtain their qualifications outside the EU, and we are using WHO support in providing this hotline dedicated for medical professionals. Also, Polish government has launched a special support program for medical universities. The aim is to enable Ukrainian students and doctoral students in the field of medicine to continue their studies. This is, of course, free of charge. And then we are offering them some preparatory and language courses. As I know that we are running out of time, thank you. I will stop here. Thank you.
Thank you. Well, it's been a really interesting panel, and I hope you learned already something, and hope you learned something from each other, because I heard a lot of similar approaches here, but implemented slightly different because the contexts differ. And I think that's really helpful. We stay in the region, in the Ukraine. There's going to be another video. I'm introducing this. So what you will see here is the outreach, is the community engagement. You will see women. And that's really important because 70% of the frontline workers are women, especially those who reach out and sit in the communities. Often, though, these community health workers are not recognized, not salaried, not trained. Yeah, and for this reason, WHO and UNICEF and other partners, we've launched now the Community Health Delivery Partnership to strengthen this. In the case we're going to see here, they are fully integrated, they are nurses, they're recognized by the primary healthcare system. So with this note, I please send the video, and then after this we're going to have some questions from the floor.
Ну як, в мене чоловік помер, а так я сама живу. Ну, здоров'я, давлення високе і сахар, ото і все. І не хорошо, щоб хорошо, і не погано. Посередньо.
ВОЗ надає медикаменти для забезпечення населення, медичне обладнання, щоб ми могли виїздити і надавати кваліфіковану медичну допомогу.
Ця мобільна клініка допомагає вам?
Допомагає, звісно.
Ну, хочеться допомогти людям, а це великий стимул. Тим більше в мене мама була в окупації, і тому я знаю всі ці тяготи, які були в людей.
Today we witnessed doctors and nurses continuing their heroic work in providing primary health care here in Ukraine. They do that in spite of the attacks on health, disruptions across the whole system, and they make the difference. We, as the World Health Organization, are here to support them, to ensure that they have also available equipment and the medicines to support the communities at the time of war.
All right, we noticed that we switched the videos, and I'm sure you love to, if you're like me, you don't probably like to listen to your own voice on video. It sounds terrible. Anyway, your voice sounds good. Mine sounds terrible when I listen to it. But anyway, it's good that you're listening now at least. So now some questions and answers, well, questions from the floor, and then please ask directly to the panel if you have specific questions. Then I will collect some questions. All right?
Thank you so much. Actually, you just mentioned that different countries requires different solution. I think that there is consensus that basically strengthening the primary health care is like a must during the response, and also when we talk about the Build Back Better recovery. One of the contexts, especially in our region, EMRO, that is very common, and Gerard actually came from one of the most problematic country, Palestine, that actually they have been in emergency situation for decades. So talking about the organizing the work of the primary health care in such protracted situations actually where especially require heavy international support. The question is that whose job is that? Humanitarian partners or development partners? And if it is both, how they can organize the work and collaboration among themselves? Can be a question for Gerard and any other panelist. Thank you.
All right, thank you. Maybe one more question, Joe?
Yeah, I've got a very loud voice. No? Okay. Oh, translation. Whoops, sorry. So the world is becoming a place of protracted crisis, and these wars and conflict and challenges continue. How do you cope with burnout? Thanks.
Well, we have a big resignation, especially of female workers in the health force, right? Good question.
Yes, thank you so much. And we've just had the example from Poland and how they're dealing with the refugees, integrating them into the existing healthcare system. But before that, we also had the example where a special team was created around 4,000, was it 4,000 population of the refugees. So two different approaches. So I think the issue of different contexts requires different approach. But my question is to Poland in terms of the humanitarian versus development. When you're integrating like this and with such a huge crisis, refugees, how do you then sort of resource these in the context of either humanitarian or developmental, and especially when you are resource mobilizing or even budgeting as a government? Thank you.
All right, I would suggest we start with these three questions. Maybe, Gerard, you start answering the first one, then to talk on also, and on burnout also, what we good to know this, and then the last one is for Poland.
Well, I think you pose $1 million question, and I'm afraid I won't have the ultimate answer to that. I think what we need It's more coordination and collaboration within the donor community. One attempt was obviously this humanitarian development peace nexus, and there are some initiatives that are working. I mean, in primary care in Palestine, we got some of the investment banks on board to invest in infrastructure and use this as a driver for health systems reform. But I think we're by far not there, and more efforts are needed to really position primary health care as an effective pillar during the humanitarian response, but breaching into the development and rehabilitation and reconstruction phases. And I'm sure EMRO is on a good way in doing that, in moving forward. So if you want to elaborate on burnout, Jarno.
Thank you. And let me maybe, if I may, 2 words on this question and experience. After 24th of February, what we discussed after a few weeks with Hans and Gerard and colleagues was that we need actually to have the principles in place, especially anticipating that many humanitarian partners are coming. So how to ensure that you coordinate, you have the development side and humanitarian side coming together. So we worked as a WHO and many of the partners to get the principles together to think how this could happen. It is not ideal. But what we learned also that as a WHO, we coordinate both. We have a health cluster with the humanitarian partners, and we have a development coordination, which is also very strong, which we both co-host as a WHO. So I think we have that mandate and role to bring both sides together. As well, many other agencies, as UNICEF and others, working also on the both streams. So I think we have that role of bringing kindly both sides, the humanitarian actors and development actors together, and then supporting as much as possible the national leadership. Because I think what is important, and my lesson learned these 600 plus days, is that humanitarian response should not weaken the national capacity. And I think that is something that we need to keep an eye and keep the principles in place. So this is something, lesson learned. I think that's a daily struggle. And then how to integrate the humanitarian partners to their data systems, others to the national system. This is another aspect we have seen, that actually those services provided by the humanitarian partners are not always recorded in the system. So how to bring these pieces together, it's not yet done, but I think that's extremely important. On the burnout, I think it's another big task for us to ensure that we do investment to the health workforce. So while the mental health services are provided to the communities and population, we ensure that also the self-help plus tools and other tools that we have as a WHO are available also for the healthcare workers. We did the same at the COVID time for many frontline workers, and especially nurses were in. Issue across the system as well, especially when we look what you and air alarms. So I think that's somewhere where we need to invest much more is the healthcare workers among the as we do with the communities. Thank you.
Okay, just before to Mohammed, do you want to say anything about the burnout? Do you have this in your state? Do you deal with this?
Well, I think then part of the things that we've experienced basically is displacement of the health workers themselves, you know, from where they are. So, but what usually happens is that, you know, when things cool down, they tend to, you know, go back and continue providing services. The second thing is around the, you know, the health worker motivation. You know, through different incentivization, providing, you know, trainings, and just as he has said, you know, providing mental health services, you know, counseling and so on. So that actually tends to help. But then, of course, coming from a region that, you know, even at stability, there is still the issue of, you know, low health worker, you know, numbers. So of course, these things are actually faced. But the other thing again is training of local, indigenous health workers, and then of course keeping them within the regions to work. That all further helps them to, because they're actually helping their own people and then working for their own communities. So that tends to assist the system to keep them within, and then of course continue together with the other strategies at retaining the health workers. Thank you.
Yeah, thank you. First of all, I would like to mark that in Poland we are quite lucky, I could say, because we've got quite similar cultural language with Ukrainian people, with Ukrainian citizens. We've got quite large part of common history, and we also had a considerable Ukrainian minority in Poland before the crisis. So this is the comment related to the context. It is easier for us, I think, within European Union in Poland to integrate patients in our general system, of course in the meaning of patients, but also with medical health workforces. Related to those questions was related to humanitarian aid and government budget financing, right? In my opinion, because it is more of 1.5 years when the war crisis started, and humanitarian aid organized by the international community was, I think that it was the first wave of response to the crisis, because everybody were concentrated on organizing support today for today. Now we are working at the governmental level for the longest period, in the long term. That's why we would like to include patients, include medical workforces to our system. I know that this is really, really important. This is a quite big challenge, that the support should be organized according to the real needs of patients, of people, of the governments, because when international community at the first days of the war, they asked us, they didn't ask us, they told us, okay, we can provide you support, but they didn't ask us what are your real needs as a government, as officers, how we can support you to organize your help, to organize your support to the refugees, to the patients. So I think that this is really, really important to remember about that. Of course, a question related to the budget. It is a really hard question as always. We decided to fund all support dedicated to Ukrainian citizens from the state budget. It is a challenging issue, but when we are including people in our system, they became a part of the system. So they also provide some profits to our system. When they are in our community, they starting to work. They work in Poland, and they start paying taxes, and this is a circle of life, I could say. So including people, inclusion at all, I think that it might be very, very beneficiary. Of course, as I said before, financing is always a challenge. We decided to finance all the support, but I think that in the long term, it will be beneficiary for all of us. Thank you.
All right, I need to be the tough time manager. Sorry, but thanks. We don't have time for any more questions because I think we have to wrap up. Correct? So I give the floor for 45 seconds to Dr. Alagüney to tell us maybe how after the and the system that after the quake. Just because I think it's also interesting to get
Yeah,
this.
it will be hard to wrap up in a short time, but as Professor Takian stated, you have to have a good primary healthcare system, and when an emergency occurs, you have to restore and adapt it to the emergency itself and reinstitute the services. So it was tough, but at the same time, it was easy for us to reinstitute the services. We have Public Health General Directorate, and it has a provincial organization, so we just moved these forces into the area. But when the system is failed in the earthquake zone, because 11 cities were affected and buildings were destructed, and people were earthquake victims themselves, the healthcare professionals. First time the volunteers and then your forced assignments with the physicians went there and gave this primary care services in that emergency situation. We had moved our environmental health department units to check the water, sanitation, and analyze the water samples. Our contagious disease and early response team made, the surveillance system, disease surveillance system, and if available, they collected ICD-10 codes from the electronic medical records or manually if the system was not working. Family medicine units were reinstated, and in the tent cities or container cities, and they replaced the physician if the physician was an earthquake victim himself or herself. So we gave mobile health services to give service to rural areas, because in the earthquake, the people moved to the rural areas. And our emergency psychosocial aid teams, they went to the earthquake zone and give psychosocial first aid to the victims and also the rescuers and the healthcare personnel at the same time. So data from all activities in the field were collected from the first week, and we are still, after 9 months, collecting data from the earthquake zone to understand if there's a problem and to correct that problem in the field. I think it's
Woo! People have listened and nobody has left the room. So we're going to wrap up now. Thanks a lot. This was a super rich discussion. I hope you can corner these colleagues on the corridor thereafter if you've got some questions. I took away a lot, but I don't even know how to summarize all of this, because you really showed to me that you're dealing it, you're adapting, you are moving forward, and you are always adapting, always moving forward, and through primary health care and adapting it to the needs. I think that's fantastic. And I just hope that you get the funding and you get the budgets and you can make it more resilient, and that the healthcare workers stay there, because we have another crisis that a lot of healthcare workers have actually left the system. And these days it's very hard to attract nurses or teachers in the education system after the crisis. So we have a big problem to take. Gerard, do you want to also summarize?
I don't want to summarize. I just want to get one key message out. I think we need to collectively do more to make primary healthcare more reputational, more prestigious. I'm a surgeon, and I'm always also a primary care physician. When I say I'm a surgeon, everybody says, wow. If I say I'm a primary care physician, I say, well, yeah, okay. Yeah. So I think we need to change that mindset. I think we need to put primary health care in front and really underline the importance and put it on the top of the agenda in emergencies and irrespective of emergencies, also in the global context of health system strengthening.
Thank you.